Hello, I'm Donal Macaulay, and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in the UK, we're in Bristol, and I'm talking to Chris Salisbury. Chris, let's take it back to the very beginning. So what stimulated your interest in medicine?
In medicine, it was quite a late thing. I was first thought I was going to be an architect, and then when I started sixth form, I thought I was going to be a vicar. And I went to speak to my vicar, and he said, "You're far too young to decide that. Go and do something else for a bit." And I thought, well, medicine sounds a kind of caring, nice, good thing to do, and I did. So I did that, and I never thought about being a vicar again after that. But I took to medicine, and I love it.
Well, now we'll have to call you Reverend from now on.
Yeah.
So then you went to medical school, and then you did family medicine. Tell me about that decision.
Again, that wasn't straightforward. I thought I wanted to do psychiatry. I started on a psychiatry training program, did that for a year, but I kind of missed. I still like it when an old lady got a chest infection on the ward. I felt I was being a proper doctor again. And psychiatry at that time felt very different from medicine. And it was also a bit slow. I'm a bit impatient. I like to be doing the next thing. And, I'd get into a stage of, oh, I've got one new patient today. I've got a clerk. And that was became, I like action and moving fast. And so anyway, then I didn't know what to do. And general practice was a sort of, well, that sounds a bit of everything. And it gave me a chance to stay in one place and not to be doing 6 months in all over the country. And again, once I started doing it, I realized this is the thing for me, but it wasn't a particularly well thought out decision to go into general practice.
Yeah, that's very interesting, because looking back to that particular time, that they were really exciting times in family medicine.
Absolutely.
Family medicine was a really top choice in many people's career moves.
Yeah, absolutely. So I was in Bristol. I loved Bristol, wanted to stay here, but everybody wanted to be in Bristol and everybody wanted to be a GP. And I knew really bright people who would be hanging around doing locums in Bristol, waiting for the job to come up. And I couldn't do that. My wife was pregnant and I needed a job. So I took the first good job in a university town in the south of England. They were my kind of criteria, which was in Reading. And there were 100 applicants for that job. It was at a time when everybody wanted to be a GP and there was a lot going on. And I threw myself into that. There was lots of things to do. We computerized the practice, we built a new surgery. I heard a great talk in Oxford by Barbara Stilwer, who was a pioneering nurse practitioner, and we introduced a nurse practitioner. She and I wrote a book together about a sort of handbook for how to employ nurses and how to run clinics and how to do minor illness management for nurses. And that was a big success, and that partly gave me the buzz of operating on a bigger scale than my own practice.
Yeah. Just to talk about this nurse practitioner and enabling nurses, of course, this is widening the team, not just in primary care, is very controversial in the UK at the moment with physician's assistants. You were pretty ahead of your time.
Yes. And I also wrote an editorial, and I think it was in the BMJ, it might have been British General Practice, about the idea of nurses being partners, and that part of the resistance to nurses was from nurses was the idea of being employed by doctors. And I was quite in favour of a multidisciplinary team running the practice, so that it was the team that ran the practice rather than just doctors. But I do understand the concerns these days about, I think one thing I've learned is that bringing different people into the team brings different skills, but we shouldn't pretend they're all the same and that they all do the same things. And they don't so much take over things that GPs do. They provide a different range of skills for things that GPs weren't previously doing. So physios, for example, doing musculoskeletal work, that's one thing, but I wouldn't have physios managing undifferentiated patients with minor illness. And I think quite a lot of the people being brought into general practice now are not appropriately trained to do the things that they are being asked to do. So it's not a criticism of them. I think there are probably some good people doing their best, but I don't think we should place people in jobs that they are not the right people to do, really.
I mean, there's a big difference between the practice nurse and the nurse practitioner.
Yeah.
Can nurse practitioners see patients on the first line?
Yes, I think they can, as long as they know their limitations and they know the things that they're not good at, and they've got a good relationship with the doctors and can talk about things. Yes, they can. I mean, I don't think every health need you have to see a doctor for, but I do think there are things that doctors are good at and things that nurses are good at. I mean, one of my particular things is I think that most people, at least in my day when I started general practice, nurses weren't terribly well trained to do general practice, but nor were doctors. In fact, nor was anybody. They'd been trained to do a very different job, and then they were placed in this thing. I don't think then we really trained people to do the range of the types of things that general practice needs.
Now, you mentioned something just a moment earlier, that it's a knowledge and a skill that has sort of disappeared, and that is you built a new surgery. That must have been a bit of an adventure.
That absolutely was. That was one of the highlights of that part of my career. Was as there was a scheme where you could get help with the interest on the buying a loan, and we took a million. It was a big risk, really, £1 million loan in those days. This was 1989. Built this fabulous building, and it was a really exciting project. I like projects. In fact, that's one of the things that gets me into research. It's not just research; it's having something to build, to make a product to work on. And it took up all my spare time thinking about windows and talking to the architect, visiting surgeries around the country to get ideas about what we wanted to do. Really exciting project.
So we move on a little bit, and then you move to Bristol. Tell us about your move to Bristol.
Well, it wasn't quite like that. So I was a GP in Reading, and I was just itchy. I was always had this sense I want to keep my career developing. And I went to do a master's degree at United Medical Dental Schools, now Imperial. And actually, no, it wasn't Imperial, it was King's now. And that was the turning point, really. It was there weren't many master's courses, and this was set up for future leaders. And there were just 12 of us, and it was all about research and teaching. And I learned about research methods and statistics and adult learning theory and educational methods and medical ethics and scientific philosophy. And it was a bit like a kind of encounter group. There were just 12 of us. We would talk about a paper, someone would present it, we'd discuss it, but we'd talk about what it meant to us in our practices, we'd critique the methods. And it wasn't as advanced a research training as some of my young colleagues do at the London School of Hygiene or whatever now, but it was a really broad training on encouraging you to think and writing essays. I can remember the first essay I was discussed the problem of trivia in general practice, and having to read all the early research about sociological sort of research about why GPs feel what they do is trivial. And I just loved it, and I found I was good at it. And my thesis, which was on how people choose their doctor, got published in the BMJ, and that was so exciting as a master's student to have your paper in the BMJ, which was the big thing to do. And that made me think, it's fun being part of a big conversation, and it got quite a lot of controversy, that paper. Being part of a controversy, I enjoyed as well.
Well, that master's obviously really set you up for your career and encouraged you to take the next step.
Although it didn't, well, it did, and I really wanted to do it, and I kept applying for jobs and didn't get them, and I kept losing out to people who were already in the university system, already had a PhD and were lecturers or whatever. And so I applied for several jobs, didn't get any of them. Eventually applied for a job that I really thought I was well set up for in London. Didn't get that either, but Brian Jarman was on the interview panel and phoned me afterwards and said, well, they might not have wanted you, but I've got someone who wants to go part-time and needs a job share. Will you do that with them? And that was in London, St Mary's. I did that. That went really well for 3 years, and that's what enabled me to get my job in Bristol, which is what I'd really wanted all along. And that's when I got back to Bristol in 1998. So if any younger colleagues watch this and feel disappointed they don't get their first choice of things, it's a torturous route for me and for many people, I think. It comes right in the end, but you may have to try a few things before you get there.
Well, after all these hiccups and hurdles, you're now in Bristol. Tell us about that.
I love Bristol as a place. I mean, it's just it's a vibrant, arty place. I love the university. You just meet so many, partly because it's a very wide university with humanities as well as sciences, and it's a very cultural place because the BBC is here, and lots of media companies here. So you constantly meet interesting people who think about things. I have so many colleagues that I just love talking to. They have so many interesting ideas. And it was a good place to come to Bristol. Debbie Sharp was the head of the department. She's full of energy and ideas and was driving it forward. Tom Fahey, one of your compatriots from Ireland, was the other senior lecturer at the time, really great guy. And we were very successful, between the three of us mainly, and a few other people as well. We applied for lots of grants, got lots of projects off the ground, and the department grew, and then eventually became one of the kind of leading departments that formed the school, NIHR School for Primary Care Research. And we are very pleased with the fact that we're one of, I think, only 2 places that have been in that through multiple renewals ever since. So I'm really proud of our department in Bristol. It's, I think, one of the leading primary care departments in the UK, which probably means in the world. So it's a great place to be, great place to live, and a great department, and part of a bigger unit now of population health, where we're working with world-leading epidemiologists and statisticians and public health doctors, and that's been a good development as well.
So you developed your research career and you have a lot of different interests. What were the ones that you started with?
I think my research, in fact, has always been, because of my background, I was 13 years as a proper, well, 10 as a full-time GP and 3 as a part-time GP. And I was always interested in trying to be a good practice, that responded to consumers' needs, provided good quality, and was efficient. And, I was trying really hard to run a well-organized, good, responsive practice that provided good care. And therefore I got involved with things like nurse practitioners and computerization and good buildings. And so a lot of my projects have been about how to do general practice better. I think that's the kind of common theme. They've often been organizational things. They've been thinking about the implications for general practice of new models of care. Quite often they've been, some politicians come up with, said, I know the problem, we just need to do this and it'll all be fine. And I'm thinking it's not as simple as that. And gone out to evaluate the pros and cons of whatever. The walk-in centres is a good example. Oh, we can't get a GP, we'll just set up this parallel service next door of walk-in centres. And so evaluated that, and what are the pros and cons, and what's the impacts on general practice.
But it wasn't just the academic side of thing. I mean, on the general practice side, you were very grounded in practice. I mean, practice wasn't a leafy suburb. It was a more deprived area.
Absolutely. In Reading, I'd worked in a very mixed area, from everything from quite poor areas in the centre of town to affluent suburbs. But in Bristol, it was a kind of condition of the job that the health authority put money into my job on condition that I went and worked in this very poor, deprived part of Bristol, in South Bristol, big council estate. But that was really good. And I had some very good partners. There were other people also fairly new there who were determined to do something about health inequalities and to provide good care in an area that had generally not had such good care before. And the health authority putting money into developing a thing called a healthy living centre, which was meant to be not just medicine, but there was a community garden and exercise facilities and things like that. So it was a good practice, and we really did develop a good practice, but actually not much to do with me, because at that point most of my energies were in the university. But the health authority were pleased because their strategy of linking academia to healthcare seemed to work, but actually in reality it wasn't really me, it was other people in the practice. But everybody was happy. But I did learn a lot about how different general practice is. In being a GP in a deprived inner city council estate is very different from working in a rural practice somewhere. Not that I've ever worked in a rural practice, but I now know a lot more about the range of general practices.
Now, there was another area in which you were pretty much ahead of your time, and that's in palliative care, because you wrote a book of palliative care.
Yes, that was because when I was in London, I was working with Nick Bosanquet, who was a health policy expert. To be honest, that didn't prove to be an enduring theme of my research particularly. It was a research grant that came up. They wanted a systematic review of all the evidence of different ways of doing palliative care, and I was new and keen and had never done a systematic review, put lots of effort into writing the grant proposal. We got it, and then Oxford University Press said, could we turn this into a book, which we did. But I haven't done more on palliative care since then, particularly.
Well, let's move on to the enduring theme then,
Mm.
as you discuss it, and that really has been your huge work in multimorbidity. Tell us how that began and how it's evolved.
That began because the Quality and Outcomes Framework, or QOF as we call it in England, came in 2004, and it set out particular targets and things you had to do within a range of the major chronic diseases. And it felt, as a GP at that point, I felt that people would come in with back pain and my computer would be flashing up. You must take your blood pressure. You've got to check their diabetes. You've got to check their asthma. And it just felt like, firstly, that everybody seemed to have multiple diseases that I was seeing, and also that it was distracting me from concentrating on the thing that the patient wanted to talk about. And that struck me as a problem, but also interesting. And the first thing I did was just count, is it true that everybody's got lots of conditions? Is it? And what we found was that about 16% of the people were on multiple disease registers, but that they took up about a third of all consultations. They were disproportionately using a lot of consultations. Um, and and they tend. I also felt these were the people who most needed a relationship with the doctor, and we looked at continuity and found that they were the least likely to get it because they were seeing all these different people. And that paper, you might know the history of this better than I do, but I submitted it to the BMJ and it was rejected by the BMJ and got published in the BJGP, and which got a modest amount of attention. But the following year, Bruce Guthrie and his team published a very similar paper in The Lancet, which got massive publicity. I've never quite forgiven the BMJ for that, but again, it's another exercise about some things work out and some things don't. And anyway, Bruce's paper was probably better in a number of ways than mine had been, but it was an interesting little story, and I wasn't, and I was just fortunate that that was the beginning of a crest of a wave, really. That's become a huge topic, and it came from me because of just feeling as a GP that everybody seemed to have lots of things wrong with them, and that we were treating a system that wasn't really catering for this. We were treating people as if they got one thing, and we were designing a system that was for short consultations for single problems. And yet we're trying to squeeze in. If you really want to respond to people's needs, you needed longer consultations, and you needed to focus GP's time on these complex patients who actually take up most of the consultations.
So that evolved, that was painting the picture of multimorbidity. You went on to run trials then.
Yeah. So I did a number of other things around multimorbidity. We looked at the economics of this, the costs of this, did a systematic review of ways of measuring, because there's still an ongoing discussion about what exactly is multimorbidity, how do you measure it? But really I was more stuff around the epidemiology and concepts and so on. But I'm most interested in how can we make care better. And I was at a GP training event that I was speaking at about something completely different. And a GP got chatting to me over lunch and said, well, what we do is we don't do all these separate clinics. We just get people in once and we do a whole person review. And it just struck me straight away that that's obviously a good idea. Why on earth don't we all do that? And then I did an event at the Royal College of GP's annual meeting where I asked people to think, imagine your mother has got diabetes and early dementia and a bit of heart disease. What care would you want for her? And I got people to talk about what care they thought, what we should be trying to do. And I think it was obvious to everybody that the way we were going wasn't actually what people needed. So then I tried to develop an intervention that would be like that, and that turned into the 3D intervention, which turned into a trial, which turned into a paper in the Lancet, which is kind of widely interpreted as being negative, but I don't see it as entirely negative. It was negative in that it didn't improve people's quality of life, but then hardly any organizational interventions in trials ever do. But it did show that on multiple different measures, it gave people care in a way that they wanted, that they felt met their needs, that reflected the kind of care they wanted, that they were able to talk about the things that mattered to them, lots of different measures of patient experience. And both patients and doctors seemed to like it, and it didn't cost anymore, and it didn't generate any additional work as it replaced. So in all those, I see it as a partial success, and I'm still pursuing that idea in a current study, trying to understand how to overcome the barriers to implementation to this kind of work.
So you're carrying on all this work, but then recently the department had a feshrift to celebrate your career. So just as a final question, that must have been a great thrill and a great pleasure to see your colleagues.
It was actually lovely. I was worried it would be a bit embarrassing and cringeworthy and everyone saying, well done for doing this and well done for doing that. But actually, it felt more like a wedding whenever all your friends were there, people you've known over your life who were there to wish you well and celebrate stuff. And, actually, I had some great talks from some of my colleagues and who I've worked with many years, and they all gently made fun of my funny ways. And actually, that made it fun. If they had taken it terribly seriously and, listed all my achievements, that would have been cringeworthy. But they made fun of me, talked about things that I do and things they'd learned from that. And I did a few reflections on academic life, and everybody seems to have enjoyed it. I certainly did. And I'm grateful to them for organising it.
Chris, as always, it's been great fun talking to you, and it's been a lifelong pleasure to have had our careers on parallel tracks. Thank you very much indeed.
Thanks, Donald. Nice to see you.